Good morning. It's my pleasure this morning to chair this session and to welcome you all to our the Future of Our Youth, our first session this morning. And particularly, it's my pleasure to welcome our renowned speaker, Dr. Alfgeir Kristjansson from West Virginia University. Dr. Kristjansson is from Iceland, one of the Nordic countries. He has been at West Virginia University since 2012. He studied in his home country in the UK at the University of Edinburgh and at the Karolinska Institute in Sweden, where he earned his doctorate in social medicine. Dr. Kristjansson's main area of expertise is adolescent health behaviours with attention to substance use prevention and community health prevention and promotion. Currently, he is the principal investigator for the Young Mountaineer Health Study, which follows a cohort of middle school children over a period of 3 years. He's also a member of the core faculty with the West Virginia Prevention Research Centre in the School of Public Health and is a principal investigator at the Centre's core research project entitled the Integrated Community Engagement Collaborative ICE, which is an implementation of the Icelandic Substance Use Prevention Model in West Virginia. Dr. Kristjansson has also worked on several federally funded evaluation projects in West Virginia as well. He's lead scientist for the Planet Youth project, which is an international implementation platform for the Icelandic prevention model and is in use across 25 countries and indeed here in Galway. Dr. Kristjansson continues to be actively involved in child and youth research with scholars from his home country, Iceland, the UK, Sweden and the US. So it's my pleasure to hand you over to Dr. Alfgeir Kristjansson.
Good morning, everyone. Nice to be here, and thank you so much for the warm welcome and all the hospitality so far. You may wonder why this is this guy from Iceland, why does he speak like an American? And when I talk in the US, they will say, well, you've some kind of a funny accent, where are you from? And so when I speak English in Iceland, people say, well, you sound like an American. So, you know, when you are from one place, you live in a different place, you sort of reach a point where you don't belong anywhere. And that happens over time. Then my children, I have 3 boys. My oldest boy lives in Iceland and has stayed there, and he likes to be Icelandic and has deep Icelandic roots, whereas my other 2 boys, they've spent most of their life in West Virginia, and they're much more Americanized than he is. So it's an interesting international real-life experience. So what I want to do as an opening speaker, I want to be a little bit broad, but I'm going to be quite critical also. I want to criticize and comment on what I have experienced over a better part of the last 2 decades in doing work with the Icelandic Center for Social Research and Analysis, and then Planet Youth, which is sort of the continuation of that center in our international projects. Since 2006, I've done work in places like Turkey, the Nordic countries, Australia, Chile, Mexico, several different sites in America, certainly throughout Iceland, and we're now working in Scotland. We have colleagues here in Ireland, so in lots of different places. And what I have experienced during this time is that there are remarkable similarities between the system-based problems that we have in all those places. Now, those places are vastly different in terms of culture and history and so on. But it's quite remarkable how common the same types of systems-based problems are across all of them when it comes to youth work and funding lines and programs and so on and so forth. So I'm going to be a little bit critical on this, and I want to use the Icelandic model as an example. You may or may not know the Icelandic prevention model. That's not necessarily important. I will explain and use it as an example of something that I think is a way to move forward, and I'm going to use that as a sort of as a case study. And to do that, I'll probably have to start with, what really happened in Iceland? Why was this an important development? So, substance use prevention, particularly from a primary prevention point of view, has historically been done with what we call instructional programs. So we tend to run primary prevention through educational programs. Primary prevention is, of course, the prevention of the onset. We're trying to prevent something from starting. And the default approach appears to be that we're going to teach kids about the dangers of drugs. We're going to try to teach them to shy away from drugs. And Iceland certainly used that approach for the longest of time. And at some point, we caught ourselves in a position being with the worst statistics in all of Europe, or among the worst in all of Europe. So despite our routine programs implemented largely through governmental funds, our position comparatively was very poor. This is in the mid to late 90s. So at the time, a team of people came together and thought, well, we probably have to change our ways here. And the interesting part about this development was that it included a collaboration from researchers, policymakers, and practitioners, including parental networks and so on. So everybody was at the table at the time. On came and what has been labeled the Drug-Free Iceland 2002 project. This is supposed to be 1997 to 2002. And this was initiated as a holistic entity to try to mobilize the whole of community in the struggle against drugs. Now the focus of this work, and I will talk about this more, was environmental change. So the idea is that kids do not randomly assign to start using drugs. And in fact, if you look at the literature into this issue, that certainly is the case. Almost all onset of drug use is initiated through peer group relations. In other words, kids don't wake up one day and say, today I'm going to become a drug user. That's not how it works. It happens through peer relations in environments that somehow allow for that to happen. And interestingly, if you look at ecological studies over time, those environments are not randomly distributed either. So it's neither random at the individual level or at the community level. There are the same kinds of environments that produce most of the users and new users all the time. And the practitioners in the room, they will know this, and they will know this better than most people. So I don't know how many practitioners I've met in multiple different countries that tell me the same kind of story. I have somebody here that is 7 years old, and I can say to myself, well, this young boy is going to be subject to my work in 5 years' time. And this is a universal story across lots of different places. The idea behind this collaboration was to work closely with local communities. Where do kids spend most of their time? Well, they spend 80% plus of their time confined to their local school community. In most places, schools are organized by geographical districts. So if schools are representative units of communities, we have something to work with to identify where most of the work needs to take place. And this is what started at this point in time. Now, we are all taught at some point, certainly in universities and so on, that research, policy, and practice is supposed to be some kind of circular, continuing entity. And but when we look under the hood a little bit, we know that this isn't necessarily the case. This relationship is much more complicated than we had hoped for it to be, usually. Most researchers are not necessarily incentivized so much to engage with policymakers or practitioners. And in fact, if we look at the way that the university research environment is conducted, the two bigwigs, the two key bean counting activities for researchers are publications and funding. Now, I understand that they may do lots of other things, but in many and most research settings, they're not incentivized much to do collaborative work. And most university professors are not also trained to do much work out in the community. As a result, the incentive for the researcher up in the basket there is to look ahead and throw out new research reports. Most policymakers are way too busy to scrutinize or review the latest research literature. As a result, most of the research reports are ending up in the ocean and or that stuffed drawer that is too stuffed with previous research papers that the policymaker didn't have time to read. Obviously, the practitioners that are supposed to look both ways are blindfolded because the relationship between the three isn't really functional. And unfortunately, even though we like to talk about things like sustainability, dissemination science, implementation science, collaboration, this is much closer to reality than what most of us live with. Now, what we obviously want to have happen is that we want to have these entities truly collaborate with one another. We want a translation of research evidence into practical settings. There is something called practice-based evidence out there. There is not only evidence-based practice, there is practice-based evidence. Evidence that helps practitioners, that guides practitioners, that practitioners find helpful and useful in their endeavors. And many of the practitioners, they will have and can have a lot of positive input into such entities. But those kinds of relationships need to come with systems-based changes. There needs to be some incentive. There needs to be time available to actually do real collaborations. There needs to be the realization that if you want to work with researchers and policymakers as a practitioner, you need to be allowed the time to actually engage in such. And my experience has been universally in all of those places that I've been to, that practitioners are just simply too busy to do that. And they are not allowed the time to actually spend time engaging with policymakers and researchers to truly impact future policy and study. So obviously there are exceptions to this, and I know that this center, for example, has been forward-thinking in terms of these types of collaborations. But universally across the spectrum, this is the problem that I have experienced. And certainly in the States where I live and have drawn much of my experiences from over the last 10 years, this is absolutely the case over there. So the Icelandic prevention model is a way to try to tackle this problem, to try to create a mid-layer between research, policy, and practice, so there is something mutual to actually benefit from, okay? So I'm gonna take a little time to try to explain this briefly. We have something called the 5 guiding principles of the model, and I will just briefly explain each of those, and I'm gonna talk about something called the 10 steps to implementation also. There are more extensive literature on this, and I'm happy to guide you through that and show you through that. So first of all, the model is about primary prevention. And the primary prevention entity is a population-wide entity. It's not just about the kids that are at risk. It's about community building, truly. So apply a primary prevention approach which is designed to enhance the social environment. The second one is to emphasize community action and embrace public schools as the natural hub of neighborhoods or area efforts to support child and adolescent health, learning, and life success. Now, schools, like I said, are representative units of communities, and as such, they can be truly central in their way of binding together practitioners, researchers, parents, and others. The problem, of course, is that, as I'm sure you know, the schools have a mission of something different than research. And many schools, actually most of the schools that I worked with, are quite tired of being thrown at all kinds of things outside of their mission. So if we want to engage in true collaboration with schools, we have to allow them to have both time, manpower, and funding to engage in these entities. Many researchers assume that schools are data collection factories. You can throw things at them and you're going to get some terrific data from captive audience. Well, if there's no money that follows, if there's no time allocated that follows, and if there is really no incentive for them to participate, why would they? Sometimes this comes, and even worse, with some kind of governmental mandate. No, you have to do this. And unfortunately, that is more common than we realize. So if we want to really believe that schools are hubs of communities, and we want them to collaborate with us in research and in policy making and in applied practice, they should have funding ways and incentives to do so, which includes proportion of time, manpower, and other resources. Now the model then is geared towards principle 3, which is to engage and empower community members to make practical decisions using local, high-quality, accessible data and diagnostics. Now this means something different than most of us are used to. So in today's system and environment, we are much more geared towards looking to the researchers to tell people what to do. This is something entirely different. This is looking towards community members to help us researchers understand how to translate findings to local situations. Now that takes not only a certain set of skills from practitioners and people in communities, it also takes a different type of character and skills from people that work in research, because we need to be able to listen and pay attention to all the knowledge that comes directly through practice. So, we oftentimes set up what we call collaborations, but the collaborations are for researchers to tell others what to do. That's not how this should work. This should work the other way around just as much. Number 4, integrate researchers, policymakers, and practitioners and community members into a unified team. In other words, if we are working together, there needs to be a real togetherness among all those 4 entities. And that means, again, incentives, time, and resources. I don't know, you probably know this, as many of you are practitioners. When things are thrown at you and you're asked to take on just another thing, no, I can't allow any money, I can't allow any time, you just kind of have to find a way to do it. And this is unbelievably universal. This is just across the spectrum in multiple different countries. So our comment here is, well, if we are going to truly work on systems-based changes, we have to follow through with adequate resources. So let's stop throwing things at people, let's organize it bottom up and really truly value their input. And the 5th principle is to match the scope of the solution to the scope of the problem, which simply means let's allow it some time. Because most health promotion programs and public health education approaches, they are funded with short-term lines, and we expect big changes through a single grant cycle or a funding cycle. And I see this, I see this nowhere more clearly than in the US, where I live, where almost all practitioners live and thrive on soft money, insecure funding lines. And they are on this hamster wheel running of funding program, new grant program, this grant program, different way of writing the same grant to try to pull in different types of money to run the same entity. And this is the history of almost everybody that works in that kind of practice. So it's an insane idea for me. It's an insane way of running human services, on inadequate funding lines. In some cases, it even does worse than good. It does more bad than good. So who are the ones that truly need such programs? They're the vulnerable kids that don't have access to much outside of their home and oftentimes come from challenged homes also. What happens? Well, they develop a trust in the program individuals, they get something they like, the money runs out, and everything stops. So we're basically instating their distrust in adults. And this is unfortunately quite common. Now, we can talk forever about how funders are a part of this problem, because funders have their own settings, they have their own aims, they have their own objectives. They want this to be worked on. So when it comes to prevention, for example, we may have to apply for money from the alcohol fund or the cannabis group or something of that nature. But as you know, when it comes to youth, there isn't one group in smoking and another group in drinking and the third group in alcohol or cannabis and the fourth group in violence and the fifth group in sexual risk-taking and the fourth group in dropout risk. It's all the same group. They're always the same. There's risk-taking kids and the risk-taking for a reason. They usually come from environments that aren't supportive enough. So the model is really geared toward, let me try, I can click this. All right, click. Yes. The model is geared towards viewing the individual as a product of four major domains in the social environment. And those are parents and family, excuse me, the peer group, the school environment, and leisure time, basically the free time outside of school. And our view is that the individual is a product of those four major domains. Now, this doesn't mean that there isn't individual variation. That's not what we're saying. What we're just saying is, if we are working bottom up from a primary prevention point of view, we should really strengthen protective factors and drive down risk factors within those four major domains, and we will have a stronger population in return, and then we can truly allocate specific resources to the risky kids that drop out of the system. They will be much fewer in return. You look at the three circles around there, the local school community is the innermost circle because that's where kids spend almost all their time. So we need to focus on these within school communities. Now, unfortunately, I have only about 35 to 40 minutes, but I could speak about this for probably the entire day. But the issue here is it's really important to understand the implications of where kids spend most of their time. Many of our programs and policies do not account for neighborhood level specifics. They are more geared towards the entire area. And there are lots of different reasons for that, political and district-wide and geography and so on and so forth. But most kids spend most of their time confined in their local school community, and that's usually where most of the risks are also. So we need to be working locally if we are able to, but unfortunately, many of our systems do not allow for that. So that's one critical problem. So the Icelandic model is not a program. It's a process structure to form, maintain, and keep running collaborative partnerships. It's sort of a layer between the policy and the practitioners, something that helps really everybody in between. Everything is data-driven. So we run large-scale survey data in schools and in collaboration with schools, and then we produce reporting that is very practice-oriented and very quick. Because that's another issue that we are always dealing with, the issue of time. Many of us set policies and run around in our practices with data that's 2 years old or older. Now, if I'm going to truly influence local communities, let's say that all of you are parents in a high school, and I'm showing you findings from the district. You're probably going to think, well, I'm not sure these are our kids, these are district level. Well, that's one problem. We're often not close enough to community. The other question would be, what if I am showing you 2-year-old data or 3-year-old data? You'd probably think, well, I think the previous cohorts were much harder than these ones. And I tell you, I've been to 1 million parental meetings, and that's the universal sentiment. There is always a need and sort of an automatic assumption for us to look away from the problem. We want to try to find alternative reasons. But if I show you findings for this particular school that are only 2 or 3 months old, what do we have then? Then we have real commitment. And this is what we want to move towards through collaborations. So, in a nutshell, we want to speed up this relationship between research, policy, and practice. And we want to do that through some kind of a systemic effort. And this is really what we thrive to do moving forward. So, the 10 steps to implementation can be thought of as either an annual or a biannual entity to nurture relationships. And step number 1 is the local coalition. Now, the coalition usually consists of people that work in practice and people that work at the policy level and researchers and parental groups, and importantly, in step 2, the funding identification. There needs to be funding to run the teams, because what we see all the time, and I see this no more importantly than in the US, we run local, what we call prevention councils or coalitions, and they're usually people that have 120% jobs doing other things. So let's stop thinking that prevention should be funded with nothing. Let's just assume that people need to be compensated for their time. So let's run those prevention teams with some funding. And that's what we are doing, and we're seeing a lot of difference. If we are planning to collect data, we need to prepare our community to do so, which is step 3. Don't just throw some data, some surveys at schools and so on and so forth. Let's assume that it takes some training to do. And then we can move forward in data collection in step 4. Once we have done the data collection, we will go back out in the community and enhance community participation and engagement. This is to let people know that what we're working on, what our main risk and protective factors are, and bring them back to our table. In step 6, we then disseminate. And we can disseminate through meetings like this, through social media groups, with our policymakers, in our many different meetings. Now, to begin with, this is going to be a little bit strange to people. They're going to be like, what is it that you're trying to do? Are you truly trying to work with us? But in reality, if we get people to the table to begin with, and we get them to buy in on our data and what we're trying to do and what we are showing them, we're going to be ready to do some community goal setting and actually work with them moving forward. And nobody is more important in this setting than local practitioners, because they will know better than most people what are the key issues. On to policy and practice alignment once we have selected our main goals, and then, only then, we are ready to work on interventions. And interventions don't have to be something fireworky, really expensive and huge. They can be simple things that don't have to cost very much. In fact, many of them don't have to cost anything. So what we usually recommend to our local collaborators, pick a handful, 3 things, to really focus on for the next cycle. And then you revisit that thing in the annual or biannual repetition. I think my clock is ringing. So I guess what I'm trying to say here, work collaboratively, collect some data, translate that data to our local communities, and value the input. Thank you. Well, let me show you one more thing, excuse me. This sequence of things that I was referring to has been published in these article series in Health Promotion Practice. Those were in open access. So if you're interested in reading about this in greater detail, it's all going to be there. And of course, if you're interested in learning more about it, please feel free to send me a message, and I will send you anything I have. Thanks very much.